Dr. Beth Darnall is Associate Professor at Stanford University in the Departments of Anesthesiology, Perioperative, and Pain Medicine. She directs the Stanford Pain Relief Innovations Lab and leads NIH and PCORI funded clinical trials that broadly investigate behavioral medicine for acute and chronic pain, including a multi-state trial on voluntary patient-centered prescription opioid reduction. In addition, she has twice briefed U.S. Congress on opioid and the pain crisis and has provided testimony to the FDA on iatrogenic harms associated with opioid tapering. She's a scientific member of the NIH Interagency Pain Research Coordinating Committee and is an appointed member of the CDC Opioid Work Group. We're happy to have Dr. Beth Darnall. Welcome, Beth.
Oh, thank you. Okay, hopefully everyone can hear me. Perfect. Okay, great. Thank you, Dr. Lewis. And I'm just really pleased to be here today, and thank you for all the organizers. Next slide, please. So chronic pain is a major problem in the United States, with up to 1 in 3 individuals living with some type of ongoing pain. It's highly impactful really across the world. We don't have higher rates of chronic pain in the United States, although we do see different treatment patterns, with the United States being a little more focused on medications than other countries. But it has a tremendous impact on quality of life, confers suffering, and is a leading cause of disability. Next slide, please. And so what we've seen in the United States is universally multiple government agencies, institutes really calling for better integration of behavioral medicine into pain care pathways so that we're treating pain comprehensively and we're treating pain best. Next slide, please. And despite these multiple calls over the last 10 years for better integration, what we see is that pain remains treated primarily as a biomedical symptom or a biomedical problem. Next slide, please. And this really flies in the face of what we know about pain, how it's best treated, and even the very definition of pain. So this is the definition of pain from the International Association for the Study of Pain. This is a striated version of a very long definition, but essentially a noxious sensory and emotional experience. And so I always like to draw people's attention to that second half of the definition, because that's where psychology lies. That's where our individual experience lies. And this is also a huge opportunity for us. Next slide. So what was nicely touched on in Dr. Hoffman's presentation is that pain is tremendously complex and individual, and it's impacted by a whole host of factors that are fundamentally psychosocial in nature. And so that we see that all of these different types of factors, the context in which we experience pain, the meaning that we give it, our thoughts, our feelings, our mood, social factors, racial bias, all of these different factors have the ability to modulate our pain and to impact what we call descending modulation, or top-down control of pain. Next slide, please. And so when we have a pattern of these factors at play, they have the ability, if the pattern is negative, if we have negative expectations for pain, if we have low mood, if we have a host of factors that combine and are enduring or long-term, they impact our long-term descending modulation of pain, or our control over our pain experience. And we see that when we have poor descending pain modulation, it's associated with a host of negative outcomes. Unsurprisingly, increased pain intensity, but also influences our the outcomes for pain treatments, and it even predicts the development of chronic pain. So highly important that we understand more about these factors at the individual level. Next slide, please. And this was a study conducted at Stanford, led by my colleagues, and we see that there's also an unhelpful pattern of thoughts, emotion, and responses to pain itself changes the way the brain functions, so that it becomes shaped towards being more attuned to pain and more responsive to pain once pain is detected. So it sort of sets up a reinforcing cycle of anticipating pain, being more responsive to it, and that this in and of itself can maintain the pain experience. Next slide. So what's really needed is for us to better characterize the needs of each individual who's experiencing pain, to apply a precision approach to their treatment, to identify the modifiable therapeutic targets, and then equip individuals so that they have enhanced pain control. Next slide, please. So if we're able to identify some of these patterns of unhelpful thoughts and emotions, we can directly target those factors. And this is important because, as has been described previously, they essentially share real estate in the brain with the same regions of the brain that are associated with pain processing. So we can de-amplify. Next slide, please. And the way that we primarily do this in behavioral medicine is through evidence-based treatments that are delivered individually or in group format. Cognitive behavioral therapy for pain, CBT, being considered the gold standard. It's got the most evidence behind it, about 4 decades of science behind CBT for chronic pain. And the way that it's delivered is usually in 2-hour sessions, group-based sessions delivered over weeks and weeks. So 8, 10, or 11 weeks of time. And individuals learn a whole host of information, acquire skills, apply those skills, and are able to discuss them with the group. Next slide, please. And it's efficacious, so much so that this working group, this expert working group for the LANCET on chronic low back pain, put forward that education and cognitive behavioral therapy should be first-line treatments for low back pain, not the treatments of last resort or what to try when other things are failing, but really we need to be shifting how we're treating chronic pain and putting this front and center, these behavioral treatments. Next slide. So that we can help move an individual such as this gentleman who's saying, there's nothing I can do about my pain, I know it's only going to get worse. Next slide, please. And help someone move more to a space of saying, okay, I have pain and there are several things I can do right now to soothe myself, to help myself feel better. This is where we want to help our patients become empowered to better control the impacts of their pain and to be able to shift their attention away from pain, feeling helpless about it and focusing on what they can do to help themselves instead. And this is incredibly important. I call pain our harm alarm. It's designed to get our attention, and it can really grab our attention and hold it. And in response to pain, it naturally elicits distress. People naturally want to escape pain. This is normal and natural, but these responses that pain naturally elicits, once pain becomes chronic, they're no longer helpful. And if we don't address them, they can actually serve to continue to amplify distress and to entrench some of these unhelpful patterns that actually serve to maintain and lead to the progression of pain. Next slide, please. And so while we're all born with the understanding of wanting to get away from pain, wanting to escape pain, we're all born with that motivation to escape pain. We're not born with the knowledge or the skill set for how to modulate pain. This must be learned. And this is really what occurs with behavioral medicine, where we help move people from a state of agitation and distress about pain. We help them learn how to calm their nervous system. And this in and of itself is not only analgesic, but it actually dampens processing in the central nervous system, pain processing. So this person, I don't know if this video is actually playing here. Doesn't look like it is. So I'm just going to describe what this video would show, which is on the left-hand side, you see negative pain mindset. This is an individual who would be focusing on their pain and worrying about it, having trouble disengaging from their pain experience. And then in real time, this is using real-time fMRI, we have that same person use some of their skills to be able to calm their nervous system, disengage from pain, and what we can see in real time is the dampening of the pain processing in the nervous system. So this is a really powerful image to share with patients and participants who may be wondering, how does this work and why is this important? Because what we're equipping people with is a skill set to alter how their brain is functioning, directly translating into their pain experience. Next slide, please. But of course, we're not interested in just helping people learn how to improve descending modulation in the moment. We want to get people lasting results. And this is where regular skills use comes in, where when people use behavioral medicine over time, they're using a self-regulatory skill set that then becomes essentially second nature. They're entraining positive neural patterns and they're extinguishing those negative patterns that reinforce pain. Next slide, please. And this was a really cool study showing how this operates on the central nervous system, both in terms of function and structure. And so in this study conducted by David Semenowitz and Magdalena Naylor, they scanned the brains of people with chronic pain before and after they received an 11-week CBT skills-based program. And what they found was that pre-treatment, people with chronic pain evidenced volumetric deficits in the regions of the brain associated with pain control. And just 11 weeks later, after they went through the skills training and they're using the skills over those 11 weeks, they demonstrated substantially increased volumetric increases in the regions of the brain associated with pain control, those same regions. And that increased gray matter volume correlated with a patient report of decreased pain, and it directly correlated with them completing various forms that demonstrated that they had better self-regulation of thoughts and emotions. So this is pretty exciting. I mean, people can literally rewire over the course of 11 weeks. And so this is, changing, altering structure and function, entrenched patterns that may have been in place for years or even decades for some people. So this is really exciting. Next slide, please. And of course, the problem is that as cool as this is and as great as the results are, very few people have access to 8, 10, 11 weeks of cognitive behavioral therapy. It's incredibly burdensome, it's costly. Most of our patients can't get access to it. So there's a practical barrier. Next slide, please. And so this is really where home-based VR comes in, where it's an exciting new venue, a new way to translate this evidence-based behavioral medicine into a format where people can self-treat at home, greatly expanding their access to low-risk, low-cost treatment we know that works. Next slide, please. So this was a study that we did at Applied VR. These are some of the colleagues on this study. This was the first study to examine a skills-based behavioral medicine program for people with chronic pain. And this published in JMIR Formative Research just a few months ago. Next slide, please. And so essentially, this is a virtual trial. So we enrolled people from around the United States who had chronic back pain or fibromyalgia. And that was the patient population, and so just broadly adults with those pain conditions. And this was a randomized controlled trial. So they came into the study and they were randomized to receive either skills-based virtual reality for chronic pain, or they received the same treatment delivered in audio-only format. So it's really the majority of the program, although they can't receive certain elements of the treatment that would have involved description of visual elements. But the majority of the program delivered in audio-only. And so this is a really rigorous test because often in sort of comparative effectiveness or comparative efficacy studies, people aren't comparing the exact same treatment delivered two different ways. So it's active treatment. And next slide, please. And so there were 97 people enrolled, and this was a 21-day program where people engaged with the skills. And here you can see the different types of skills that were involved with the VR program. So CBT-based skills. There's also just really core elements to pain management with the dynamic breathing or diaphragmatic breathing, and also some mindfulness principles as well. Next slide, please. Okay, so this shows you one of the modules in the virtual reality program. You can see this one here is actually providing pain education, so people learn about pain, how it's processed. And then we have these interactive elements where, now this is of course swimming with dolphins, so this is just a relaxing, peaceful one, but a couple of these, both the tree elements as well as the pond element, those were interoceptive modules where an individual is immersed in the VR environment, and the device is responsive to a person's physiologic indices and is able to provide an enhanced biofeedback experience, so that as a person is calming their nervous system, the elements in the environment are calming in tandem with them, while a voiceover is reinforcing those elements to them. So in this first RCT of the skills-based program, again, comparing audio only to virtual reality, what you see here, this is one of the data slides for comparing the two groups, and you see a downward trend for pain intensity for both groups, basically pre-treatment to 21-day end of treatment. And that's really unsurprising because remember, these are two active groups, but what you'll observe is we had superiority for the virtual reality, suggesting that the immersive effects of VR really confer superior benefit for symptom reduction, this one being pain intensity. Next slide, please. And then this one here, data slide looking at activity interference over time, same trends, but downward trend for both, improvement, but superior improvement for virtual reality. Next slide, please. So we looked at a range of factors, specifically looking at the basically how pain interfered with activity, sleep, stress, and mood, and we found clinically meaningful reductions for the VR. Next slide, please. And so now, what are we doing? What are the next steps? Well, now we're doing follow-on studies. We are basically in stages of data collection for a follow-on study that is a much larger trial. It's also a virtual trial, meaning people from all over the United States are enrolled in it. It's back pain. Again, it is extended to 8 weeks. So remember, that pilot study I just presented on was 21 days. This is a 56-day program. So it's extended. People engage with essentially one session per day. We have enhanced content with those interoceptive modules for CNS calming and biofeedback, and an enhanced user experience. It is also an RCT. And in this new study, we're comparing the active EASE VR program, the 56-day program, to a sham VR. So this allows us to really control for the placebo of device usage. And then lastly, I just want to mention that with another study that is being conducted with applied VR, not the one I was just describing, we're also integrating in social elements where people who are in the virtual reality can also participate in group based support where they are able to enter the VR space with other VR users and engage in a discussion about their experience with VR in a virtual room that is being therapist-led. And Laura Garcia at Applied VR is really doing a tremendous job leading this effort. So just demonstrating some of the new directions and promise with VR. Next slide, please. And so with that, I just want to say thank you for allowing me to share our exciting updates for VR for chronic pain.